Africa Health Collaborative, the Africa's Health Workforce Crisis, insights from Ethiopia, a kind of independent review. Although we are under the Ministry of Health, we are expected to provide, recommendations, insights, and also advices. So first, let me start from the global and regional situation. So based on the human resource force, workforce 2030 by the World Health Organization, if you see that document, the overall goal is, as we know, it is to improve health outcomes. That is the ultimate goal of really having a strategy on human, on the workforce, health workforce, through adequate investment and effective policies. And investments are very important, and we'll see them later on. In this area, we see persistent challenges, and these persistent challenges require a paradigm shift for countries. For example, so maldistributions, particularly in low-income countries or low and middle-income countries, maldistributions, rural, urban, and so on, and inefficiencies of their workforce as well. The other area is a challenging area is aligning education and labor and the health labor market, so which requires policies because the population needs are usually evolving. And the third one is creating qualified employment opportunities, particularly for women and youth. So if we see this graph, this shows the estimated stock of health workers by WHO region. Can you hear me?
You are breaking. Perhaps you remove your video so that you are.
Yeah, because the internet is fluctuating. Yeah. So you can look at the African region, for instance. The stock is 2.6 million, and you can compare it with the Americas, which is 11.8 million, and you can look at it with the Europeans, which is 12.5 million. And you can see also the population, which is really even more compared to some of the continents. So Western Pacific, 15.3 million. You can see also the number of doctors, which is very low in the African region compared to, again, the Americas and also the Europeans and Western Pacific. The nursing, the same also, very low in Ethiopia, midwifery and others. Now, the other one is the distribution of the global health workforce shortage. Let's see the shortage also. So projected for 2030. So if you see this, which is a recent document, maybe about 9 years now, the projection. So you can see that the African region is now, if we see 2023, it's about 40% the shortage for 2030. But 30, it would be 51%. It would be 51%, even more. So if you see the shortage is high in 2013, 2020, and 2023, but you see the trend. It gets narrower, it gets down, decreases. But for the Mediterranean, you see it's almost the same than the African region. Sorry, maybe. Okay. Okay, now let's go to the major declarations focusing on Africa, which is very important for our discussion today. We can talk about, for instance, we can mention the Abuja Declaration in 2001 on increasing financial resources for health. We can, in 2008, which focused on primary health care and health systems, where the human resource for health was central. We can take also the Algiers Declaration the same year, where the most important area was investing in research, health research, and HRH research or evidence was central. The Kampala commitment, there are many Kampala declarations, but the commitment, if you see that, it focused on primary health care and family medicine. The Africa Health Strategy 2016 to 2030, it also prioritized human resource for health. And the WHO roadmap for scaling up HRH for improving health services in the African region, again, from 2012 to 2025, it focused. Also, there are also other declarations, but these are really including the Bamako in 2011, which focused on human resource for health. So the next question is, what are the factors for health workforce shortage in Africa generally? What are the most important factors? One is inadequate training capacity. I was reading one of the documents, and if you see the training capacity of Africa, there are only 168 medical schools, and it was amazing for me that about 37 of these countries, African countries, had either no medical schools or only one medical school. So you can imagine, how our training capacity is very low. On the other hand, we have a rapid population growth. Many of the countries, there is international migration also. This is also very well known. We'll have an example later on. And weak governance of the health workforce in many of the countries. Career changes of the health workforce. There is also poor retention of health personnel because of weak governance of the health workforce. And it's also projected that shortage will reach 6.1 million health workforce by 2030, which is almost 5 years from now. And according to the estimates, the health professional to population ratio in Africa is about 1.5 per 1,000 population, which is far behind the 4.45 SDG threshold. This may be very low because in that report, they really used data from 47 countries of Africa. So what about the rest of the countries? Maybe they don't have data also. So this figure may be lower than that. I like this figure by Wojcicki in 2004 because it gives really a very clear flow chart of individuals into the health labor market, a kind of economic analysis. Students going to high school, from high school, either they go to a health training institute or not, or other training institutes. If they go to the health training institutes, then they full of qualified health workers, outward migration, or like developed countries, adding to the pool, immigration. So we don't have the luxury of this one, immigration, but we have migration instead. But from the pool, you have either they are employed or they can be also out of the labor force, or they can be unemployed. We have seen also this in Ethiopia. And those employed can be in the health sector or they can be in the non-health sector. So let's go to Ethiopia. So let me give you some highlights about Ethiopia. Ethiopia has a population of 128.7 million as of 2023. Actually, now in 2025, it's expected to bypass 135 million. And by 2050, will be 225 million. So you can imagine, really, we are the second more populous country compared to, next to Nigeria. Life expectancy is 67.8 years, almost 68 years. It increased by 17.1 years from 2000 to 2021. You can see the effort here, whether it's health related or non-health related development of the country, because it increased by 17 years in these 11 years, in these 21 years. The GDP growth rate is 6.5 on average. From the Ethiopian perspective, it's higher than that, but at least internationally, on average, it's 6.5. And we have a population growth rate of 2.6% every year. The fertility rate is 4 births per woman, according to a 2022 reports. And the per capita income, we have come really from a very low per capita income, at least to 1,000, more than 1,000, 1,272 in 2023. And the maternal mortality rates, I tell you, while I was a student in the 90s, 89, 90, the maternal mortality rate was more than 800,000 for a PhD study. So you can see how much we have come, 194.9 or 195 per thousand live births. And neonatal mortality, the same, we have shown a really marked improvement, but still very high, both maternal mortality rate and neonatal mortality rate. When you see the share of deaths by broad causes, maternal, perinatal, and nutritional causes are the most important ones, followed by non-communicable disease, injuries, and others. And you can see really transition, or we can talk about it later on, about the dual burden of diseases. Coming to our health and administration arrangements, we have a 3-tiered healthcare system. If we start from the bottom, which we call primary level healthcare or primary healthcare units, which includes a primary hospital, a health center, and a health post, particularly in rural areas. A primary hospital serving 60 to 100,000 population, and a health center 15 to 25,000 population, and the health post 3,000 to 5,000 population. Health post is the lowest, it's located in the lowest administrative structure, which we call Kabale, that probably are around 3,000 to 5,000 population. In urban areas, a health center serves 40,000 people. So we have really a decentralized system. Under the federal government, there are regional states, which these regional states, they have different structures like zonal administration, which serves as a liaison, because some of the regions do not have this. The decisions are taking place at regional and Wareda level, and they have councils. And then Kabale administration, which we call, they have a cabinet at the same time. So this is, so at the federal level, you find the Ministry of Health, at the regional level, the regional health bureaus. At zonal level, we have zonal health departments, and Warada level, which is almost a district, we have Warada health offices, and then health posts at the lowest level. So this is just an example. This figure is an example to see really where were we, at 2007 and 8, for instance. If you see the density of medical doctors, for example, you can see 0.03 per thousand population, which is very low. Nurses and midwives, 0.28 per thousand population, very low again. Nurses, doctors, and midwives combined, 0.31 per thousand population. So very, very, very low, as you can see. Then looking at the Ethiopian doctors and nurses abroad by country of destination, talking about, outward migration. Here you can see in this data, for instance, the domestic stock was 1,310 in 2000. But the total migration was 553, which was 30% of the stock. And for the nurses, similar, it was about 17%. So you can see that really the number of doctors very low, and then and nurses was very low, and then there was also outward migration, which is very, very high during that time. So really, it is a crisis. Then really based on all this information, let's see the Ethiopian experience and the actions taken by the government. So I have used the human resource for health strategy of Ethiopia, the WHO strategies, both the Afro and WHO, and the World Bank and other studies. In 1993, when there was a change of government, we had a policy by the transitional government of Ethiopia, which was a bit elaborated compared to previous policies. And it was PHC focused. In fact, we started PHC in the 70s, but in this one, it was very well elaborated. And there was disparities among regions, rural, urban, and also pastoralists in the distributions of health services and health workers. Ethiopia was war-torn and needed rehabilitation of the damaged ones, and also expansion of the health facilities to meet the needs because the population has already increased. Ethiopia developed and implemented a health sector development plan 1 to 4, each of them about 5 years, from 1997 to 2015. So it was really a continuous learning from HSDP1 to HSDP4. We learn and then we implement new things. We learn and we implement new things. And then after 2015, we were able to meet some of the MDGs, like reducing child mortality rate, reducing maternal mortality rate, control of communicable diseases like tuberculosis, malaria has been really good, including HIV/AIDS. We are successful in that because we introduced some innovative programs. Then building on this, we also developed a health sector transformation plan, which is called 1 and 2. And this ran between 2015 to 2025. So it will end this year. So we are in the second health sector transformation plan, which is almost which really a reflection of the growth and transformation plan of the country for economic development. And then we revised our health policy in 2024. It's not available in English, but in Amharic, considering the changes and contextual factors. So what are some of the contextual factors? One is, as we have seen earlier, there is a growing economy. So growing, economic development is good, except in some years. We are consistently growing. There is a growing population as well. There is a shift in disease burden. Actually, it's good to say really triple burden of diseases like infectious, communicable diseases, non-communicable diseases, and also injuries. And then the demographic changes also, some of the people getting older as life expectancy increases, and the pandemics starting from HIV and learning from that, and also the COVID-19 pandemic and the conflicts and displacements that are existing today, and they were also during that time, and climate change associated with drought, and also malnutrition, poverty, urbanization, rural to urban migration, as well as expansion of the urban areas, and equity, which is a question taking our three areas: agrarian, urban, and pastoralist communities in the Ethiopian setting. So what did we do? Ethiopia's accelerated health workforce reform. This, for instance, the accelerated expansion of primary health care was introduced. This included expansion of health centers. Instead of hospitals, we expanded health centers, health posts, and primary hospitals. Primary hospitals to a lesser extent, but really we expanded health centers and health posts. And then, which we call a primary health care unit, including all this. We also introduced an innovative program. We call it a flagship program, the Health Extension Program, HEP, in 2003, after piloting and pre-testing. And also, along with that, at a later stage, we developed, this had 16 packages, and then 2 packages were added. And then at a later stage, we developed essential health service packages, which was about 1,019 packages. And also there is reintroduction of the mid-level training. During my introduction of when I talked about my connection to the human resource or health workforce, this was one of the areas. It started in 1996, 1997. See, in old training institutions, and I was coordinating this some of these programs, and these old institutions were organized under the Ethiopian Health Training Initiative. And then also, besides the health officer program, there was emergency surgical officers. They were trained also as well, along with anesthetics, because there was no opportunity to train and deploy surgeons and also anesthesiologists. We also implemented task shifting and task sharing from medical doctors to health officers, mid-level trainees, and also from those to nurses and also to health extension workers. And in 2012, we introduced a flooding strategy from this piloting, from using a few institutions, medical and mid-level trainings were introduced, in large volumes. So speed, volume, and quality were emphasized here. You can see the question I have put on quality. Then there was expansion of university and medical schools. from 18 new medical schools, because these were, continuously, we are having new schools, but there was a rapid expansion. So 18 new medical schools were opened, and there were also 9 private medical, health institutions. By 2023, we had 48 medical schools, 26 under federal, 13 under regional, and 9 private. And we increased the intake by existing medical schools 3 to 4 times their capacity. So you can underline this, 3 to 4 times their capacity, with the same facility, with the same staff, with the same, patient care facilities and resources and technologies. But the government increased investment in tertiary education in general. So there were many universities, as you can see. We accelerated also the health officer training program from the pilot phase to not pilot phase, from few institutions to, a number of institutions, including 20 non-teaching hospitals. So you can see that these are non-teaching hospitals. They don't have the experience, with some support, developing materials from the initiative supported by the Carter Center and the Ethiopian Public Health Training Initiative. Then you can see some of the results. We increased the ratio of health officers to population ratio by 3.7 times within 5 years. Also, we introduced accelerated midwife program similarly, and established 15 regional health colleges. There were regional health colleges. They are doing upgrading of nurses and also doing upgrading of other health professionals. So to staff 3,516 health centers. The midwife to population ratio improved by almost 3 times. And we introduced new medical education initiative at the same, NEMI we call it, which is a problem-based learning. So we increased it from 11 medical schools to 24 medical schools. So it was more than doubled. So the number of graduates grew from total outputs of 336 graduates per year in 2010 to expected graduates of 11,291. So when you calculate this, it's about 6 times for a 6-year training program. 636, it was after, expanding a little bit, adding some new, opening new universities and so on. But when I was trained, it was about 250, not more than 250 or 60 students from 3 old medical schools. The number of graduates is expected to be more than 300 per year after 2018. So it's about 9 times higher than compared to 2010. And medical graduates would increase from nearly 10,000 to 15,000 in 2025. You see a government commitment. So without the government commitment, we can do nothing. And the health workforce grew by 84% from 2015 to 2020 within 5 years alone. So just giving all this data, what are the lessons from Ethiopia's experience? One is the need for careful planning and prioritization of categories. We decided mid-level, for instance, and also producing medical doctors at the same time. But it needs a careful planning. You remember, I put a question mark, speed, volume, and quality. Quality can be, compromised if we are not prioritizing, because, investments not be sufficient. There needs to be a political will. So political will is very important. The government was determined this time. a need for upgrading skills for new cadres. For example, we had health extension workers. Initially, they couldn't do, for instance, delivery services. But through time, the package increased from, 16 to 18, and delivery services also was included, and their career structure as well, learning from the problems we faced. But the salaries health extension workers is cost effective, salaried. They are salaried. We call them as our community health workers, because they are really bridging community health workers and the health system. Task shifting improves efficiency, as you have seen. Rapid expansion can face difficulties, like number of facilities may not be adequate in the same institution, or a total number of facilities. Staff, it needs continuous upgrading. We introduced a new curriculum. So, new curricula, problem-based learning is entirely new curriculum. It's very difficult. First, you have to convince the existing staff, and then the new staff has to learn this, because most of our juniors, because of the expansion of the medical schools or training institutions, whether it's in private or in the government or public, resources, and also technology. It needs really strong monitoring and coordination as well. That's one lesson we have learned. The monitoring and coordination should be very strong. Deployment of surgical officers and nurse anesthetists was efficient as well, because we couldn't afford surgeons at a district level or at the district hospital level, but we managed with this to handle emergency surgery. And potential wage saving was taking the health extension workers about 20 million per year. What are the challenges from at least from the World Bank and other assessments? First of all, there was a mismatch between skills taught and skills needed or required by the system. Because, we have said there are so many deficiencies. So the skills that students have would not meet the skills that are required by people or patients or, users. So that affects trust as well. Lack of fully developed licensing system to regulate the quality of staff. Now, this has started very well. In Addis, for example, 80% are licensed now. But we did, if we go to the regions and then down to district and zonal levels, then it would be lower and lower. So a strong system is very important, including regulating the private institutions. For example, if you see, there was a qualifying exam as an example, and from the private institutions, the pass rate was very low. It was about a third, while it was about 3/4 in the public sector. So it needs that kind of regulation and support system. Insufficient funding to scale up medical education. High tertiary education spending, the government has already done. Decentralized system with substantial regional variations, capacity constraints, physical constraints. Remuneration system for health professional does not set the right incentives. Weak health force management and planning. Lack of data and the analysis itself, making it difficult to plan the health work. Many health professionals are leaving also to join the private sector and go abroad. And now still we're facing conflict, internal displacement, emergencies, damage to facilities, and impact on HRH, which we have to overcome. So this is my last slide. This is what these are the recommendations. One is to invest in high quality education and research, including strengthen the licensing and regulation system, both public and private, particularly the private should be emphasized. reform tertiary education to train more medical and health workers, increase government funding, at least to the health workforce, because the spending is already high in tertiary education. Transform health workforce management and planning. Data is very scarce, and we are not using, technologies are fragmented as well. In some, you can see it in some hospitals, some regions, some trials, but really we don't have the system. We can say expand collaboration with the private sector and protect the healthcare workforce. Thank you very much.